were willing to go through the process of rehearsing with us, because you have to rehearse those 5 minutes. You can't just talk extempore because the slide moves in I believe 15, I think you've got 15 seconds per slide, and that's a total of 5 minutes for 20 slides. So you were an enabler from the get-go. What does one then, if you were to extend this concept, not just igniting, but other initiatives, other interventions in an organization, then there's the culture of culture of innovation, or culture of organizations, or organizational culture, if I may. It could be teaching, learning, it could be academics, education, research, innovation, doesn't matter. But if you've got a traditional mindset, which is unwilling to budge, and then you have the millennials and the post-millennial mindsets that are much more inclined to fast-paced processes such as Ignite or hackathons and so on. And then you've got people like us, perhaps, who are neither here nor there, and we're like kind of confused. We have to talk to the older folks, we have to talk to the younger folks and connect with both sides, perhaps. Your experience of working in Sweden, perhaps, or in the UK or other places, and where I'm not asking about traditional academic medicine. How about newer approaches? How does it work for you at Uppsala, for example, Uppsala University, and when you have to work with students or residents, and they're asking or they're thinking about new ways of approaching teaching, learning, or problem solving? What do you think about that?
Yeah, well, I haven't used it as yet in Uppsala. I've taught mainly on longer courses and fairly traditional style. I mean, I tend to use a dialogue type of teaching because I don't like one-way teaching. But I would be very interested in starting some Ignite style teaching up. It would obviously require some pre-course preparation from the students, but I think that would be time well spent. It would also potentially be quite a reasonable way, I don't know what you think about this, of summarizing projects that have been done. It's not quite the same, it's not the innovation, but it's the same style of presentation could be used to summarize a manuscript, even in a journal club sort of setting. Just a thought. That wasn't the pre-thought through thoughts. It was just a spontaneous one.
No, that's good too. Yeah.
But thinking on your feet is such a it's such an important quality to have, I think, and it's very easy to let it go dormant and atrophy.
Journal club, actually that's interesting, because we've also done we've tried to tweak our own journal club, and we have an innovation centric journal club in which the articles being discussed are specifically, or at least relevant to, innovation or entrepreneurship and low cost innovation entrepreneurship. But it's interesting, so we haven't really thought about, like, can one do like an Ignite kind of a presentation around a journal club article. Worth thinking through. Okay, so let's move on to another question, and I'm trying to kind of like connect it with your experience of coming to AKU or working in international child health. How is that? What have you learned from that? And how is that influencing or informing your outlook while you're working in Sweden?
What, being at AKU, or having worked internationally, or
internationally? Let's broaden it. Yeah, internationally.
Okay. Well, I mean, to be honest, it's I've been doing this for so long, I can't really imagine anything else. So it's more than half my life, I would say. So it's I can't really think of a time where I wasn't in some way involved in international child health in some capacity, anyway. it's hard for me to compare, but it pervades almost all parts of my life really. When I'm here, I use a lot of international examples in teaching, whether it's clinical or academic, yes, I can't really, as I say, compare to another period when I wasn't doing it.
So you've traveled to a lot of countries, and what are the differences? What are some of the key differences, let's say, between what you've seen in Pakistan versus, let's say, India, Sudan, or Papua New Guinea?
Yes, well, because I'm based at AKU, which is quite different even in Pakistan to many centres, and very different to most centres in the other countries you've mentioned. So I was in Afghanistan 30 years ago, and though close to Kabul, in quite a rural area, so very different. I know that was a non-academic post. I worked largely in a rural primary healthcare clinic for civilians and mujahideen. In Sudan, I was involved in a primary healthcare project in the desert out near the Chad border in North Darfur, and then briefly in Khartoum in a leishmaniasis project. Papua New Guinea, I was at the university, which the central university. This was some years ago, so not equipped in the same way as AKU is now, but in terms of academic forward thinking, similar philosophically. In India, I worked as an epidemiologist, largely involved in a trial in the slums, looking at a maternal food-based micronutrient supplements, looking at fetal growth and birth outcomes. So all quite different settings. So it's slightly hard to compare. What I can say with certainty is I feel very privileged to have a base, my home at AKU, because there are so many different strands, both in the traditional academic and rural, peri-urban work, community work, and yeah, I feel very privileged to be part of and contributing, I hope, in some way to AKU.
How long have you been? So you've been coming to AKU for about 10 years?
It's almost exactly 10 years.
About 10 years. How have things changed over here? What do you feel? I mean, within AKU, or do you also kind of, because the kinds of studies that you're involved in, I mean, are you heavily research based, or because I recall that you tend to be, you teach more. I don't know if, and we've done some research work together, but that's kind of limited to the emergency department.
Yes, so I do a mixture. I'm less involved in direct research now, though supervise or co-supervise several PhD students there. So my research exposure, most of my research exposure now is through them, but I'm involved or peripherally involved in a few other projects which are starting to get off the ground now. So, but I'm less directly involved in research. It's more teaching, mentoring is always a big part of it. Yeah, and then of course the courses or lectures I do. But so a lot of it is mentoring, some PhD supervision, still some research, but perhaps slightly less, smaller proportion than 5 years ago. And yeah, and general mentoring.
That's and you do a fair amount of clinical work in Sweden.
Yeah, in Sweden I'm essentially have a full-time clinical job. as well as my editorial job, which is another nearly full-time job. So as editor of Archives of Disease in Childhood. Yeah.
So pediatrics in Sweden, in a high income setting. So well, tell us a bit about, so what's the structure over there? So is it insurance based, or
it's very similar to the UK NHS philosophically. It's slightly more provincially funded, but in essence, it's free at the point of presentation. It's in essence. So very much state funded. Taxes here are high, very deliberately, in order that this that health and social care particularly are covered, and that goes back, I think, in Sweden maybe 80 to 100 years or so. It's very deeply ingrained in the fabric of Scandinavian society as a whole.
And I'm assuming that child health over there, or pediatric, I guess, parameters of growth and development, those aren't major issues, and kids are probably doing well over there in terms of growth and development. And then you come over here and you see the issues of what one would assume to be issues of low income setting or low middle income setting. So how does it play out for you? Like, is the analogy or the difference or the contrast very stark for you?
Well, again, if I was new to this, it would be, but it's so familiar for me now. I can't. Yeah, it no longer startles me in the same way. And although problems in LMICs are more obviously eye-catching or hard to ignore, I would say children worldwide have issues which which in their own ways need to be addressed.
That's a good point. Yeah. So, so as an editor for the editor-in-chief for Archives of Disease in Childhood, when you think about publishing, there's several students over here, or physicians or researchers are interested in publishing their own research. So for them even to think about, like, okay, so if it's relevant to innovation, let's say, and there's not enough evidence for such work, especially in our kinds of settings, and that was my experience, that was our experience with CCIT, and then our first evidence-based, I mean, if I may, or referenced article was published by your journal, and so how is that experience? So what convinced you that something like this, without that level of evidence, could be published in a journal? And so how do you look at it as an editor, as part of the editorial board? Do you look for like a certain amount of evidence before it is checked off and then it gets published? Or I'm talking about specifically about new ideas, so innovation, creativity, perhaps entrepreneurship, and when you don't have enough evidence to begin with, then does it get published then as an early stage thing without enough data around it? Does the question make sense?
No, it makes excellent sense. So so one thing I forgot to mention earlier on, I do a lot of or I help with a lot of manuscripts. So I'm asked for advice on style, content, and so on. I do a lot of that, so that's relevant to what we're talking about now. So I mean, I guess my rule of thumb is as long as it's so factors that influence me in my initial screen of a paper include scientific robustness and methodology. If there is a a hypothesis being tested, but that doesn't apply to all papers. Number two, that it's of relevance and potential importance to children in any setting. And number three, that it's novel. And number four, that it's appropriate for the journal. And we're a very broad journal, and but most of our readers would not be taken with very high level molecular biology, and it's just of reasonably direct bedside clinical relevance would be another screening tool, so that's how I filter out. I get 2,500 papers a year, and I have to check through them pretty quickly as a result. So when it comes to an Ignite type idea, or just a new idea of any sort, I think if it fulfills the potential use and for children in some setting, that it's novel, a refreshing idea, and will be of interest, it fulfills most of the criteria. And we have a new section which I introduced a couple of years ago called the Viewpoint section. And I think a lot of Ignite ideas would fit well into the Viewpoint format. So it's 1,200 words, 7 references, if you need references. I think that would be a useful platform. Traditional letters are okay, but I think you can get more into a Viewpoint. Obviously, they would go through the same sort of scrutiny as other papers in terms of being sent to an associate editor, who then makes her or his own judgment and then sends for external review if appropriate. So it's, the process is similar, but I think that would be a sort of format that would fit the Ignite pieces nicely.
Yeah, that's good to know. So for people who are listening, if you have if you have ideas, you don't need to have all the evidence that the idea is actually going to work, because for the Viewpoint section for archives of disease in childhood, that could be a very useful, very relevant piece for that particular section, right? So that's what Nick is saying. Nick, so just kind of broadening this concept of academic writing or biomedical writing, do you think there's a need for academic biomedical writing or publication to innovate as well? There are limitations. I mean, I'm a clinical researcher, so I've been in this area for long enough. How many people actually read biomedical papers? And this is not, you don't have to answer this from the perspective of your journal, but generally, when we talk about impact, then if you don't have enough people reading a paper, but you're just kind of checking off because you have grant funding and you have to publish or perish, you're an academic physician, so on and so forth, right? So, but what about impact? And so one publishes, how impactful is that? Then what are the outcomes? I don't know, maybe this is a very open-ended, kind of very broad-based question, but my earlier question, maybe there are multiple questions in here, but is there a need for academic publishing to rethink what it's doing, or for it to innovate?
That's a very good question, and the honest truth is, I don't think I can fully answer that. I would like to say absolutely not, that that academic platforms aren't essential for new ideas. The reality, though, is that no idea arises completely in isolation. There's always a context, a perspective, a background surrounding the question, however innovative the idea. without some knowledge of that background, the potential of that idea would be hard to estimate, I guess. I'm not sure if I've described that very well. That doesn't mean, though, that innovators have to be well read. But I think to present the data or the idea to a wider audience, it will still need some context, perhaps from a collaborator of the innovator, or but it would be hard to present an idea without some perspective. As to how many people read scientific papers, I guess it depends on how you define read, and whether it read of the abstract, which is what a lot of people do, or a read of the whole paper word for word, which far fewer people do, unless it's very much a research area of interest, is more debatable. We'd all like to think all our papers are read word for word, but we all know that that's not actually the case. That's the reality, and we know that a lot of younger readers stroke listeners prefer to get their information from podcasts, and that's something I've been trying to enhance for some time now on Archives. And we have a few running. We have a podcast on the column I write, Atoms, every month. You can get that on adc.bmj.com. So and you just look under podcasts. So that's one I do. One of my colleagues, who's an expert in evidence-based medicine, Bob Phillips, writes one called Archimedes. And you'd like these. These are innovative. So these are ideas. These are basically a look at what's out there in the literature for very specific, slightly left field research questions, the sort of which might come up on a ward round randomly, for which there isn't the evidence for a systematic review, but each of them tries to come up with a reasonable answer with a clinical bottom line. So it's not quite like Ignite, but it's on the same sort of lines, really. Quick thinking. I think you'd enjoy those. That's called Archimedes. Then we have an advocacy spotlight called Viewpoints. And of course, there's an advocacy podcast called Spotlight. And then there's a fetal and neonatal one. But you'll find them all there on the website.
Great, thank you. So that's good to hear, right? So you people have already been working on innovating through podcasts and
sort of, yeah.
those kinds of initiatives. Okay, so that's good to hear, right? So when you have an idea and you might not have enough evidence that will work, but that is just the right kind of a write-up for certain sections of biomedical journals.
Yeah.
There are also blogs, right? So journals, a lot of these journals have blogs as well.
Yeah.
And so once someone like Arfa is one of our innovation fellows, and she's very much into academic and non-academic rating. So I've been telling her similar things. Well, and I've done this myself over the past several years. That tried different ways of putting content out there, and not everything has to be referenced and cited. And narrative medicine is another area we've developed or worked in further through just patient encounters or storytelling in medicine. And so that's another question for you, Nick. What's your interest or understanding of narrative medicine? So if there's if the patient-related stories, do you cover those through your journal or through the podcasts? What's the role of such stories as a creative tool to enhance compassion and empathy amongst our healthcare professionals? Nick, you've got to unmute yourself. Sorry.
Very interested in that. When I I started, with a colleague, set up a new section called Voices, which some of you might have read. It's a banner section. There's 1 or 2 articles every month, and the Voices pieces were originally intended to be largely narrative accounts from either written by children or children with their parents. But it developed, so there are now several more spoke. So we've had a lot of voices from history, so historical events, which in their own way, the evolution of how management of whatever condition evolves has been very, very popular. It's a form of narrative in the same way as the personal accounts, and they're often very personal. We had a fantastic piece recently on the evolution of a adolescent and drugs service in Boston at the turn of the 1970s. At a time when drug misuse was extremely high. And I found that very touching. And that service is still going. In fact, it's gone from strength to strength. So that's, I'll send you the name of the author. I can't remember off the top of my head. And then voices from literature. So looking at child health through the prism of books, which we've had some excellent articles in that format. So yes, so I guess that's our contribution to narrative medicine. And then of course there's the viewpoints, and we don't really do personal views in the same way that we did, because I think we've got enough other fora to not need that specific section.
Great, thanks for telling us about your approach to narration or narrative medicine. I'm just waiting for people to kind of put some questions or comments. Anybody interested, go ahead, unmute, and then you can ask. So Nick, tell us a bit about your interest. So you play in a band, and you have shared some of the music with me before. Tell us about that.
Well, I did play in a band called the Croquet Field for a number of years, and well, music's always been in my blood, and so this was started as a 3-piece and became a 2-piece. So I wrote the songs and did the vocals. I hesitate to say singing. I did the vocals and played the guitar, and in our first incarnation, we had a bassist and a drummer, and then the bassist, for reasons unrelated to music, had to move on, or couldn't carry on, unfortunately. And the two of us, Kerry, she was on drums, and I carried on for another 2-3 years, something like that, and played quite a lot of gigs in London, recorded a bit more. We recorded 3 albums in total. And then it sort of just came to a natural close. And I carried on playing solo for, well, it hasn't really stopped, but it at reasonable frequency for a few years more, but it sort of dwindles. And but I mean, it's sort of rekindling at the moment. So I'm hoping some new ideas, and it's one of, as you know, it's one of these things you can't really rush. The ideas are either there or they're not. You can't force yourself to sit down and write a song. You just they come to you rather than you finding them.
Do you feel like you have to play something before you edit a paper, or after you've edited a paper or something, to de-stress?
No, I find it de-stressing, but it's rare that I get a paper that stresses me up so much. There's an editorial aphorism in that you shouldn't lose sleep over papers you've rejected, but you should over those you've accepted, which turn out to come back and bite you for whatever reason.
So Mary,
I've had a few of those.
Marine was wondering if you could play something for us. Do you have anything that you could play?
I do, but I had to send it separately because
Okay.
I'm in the middle of a talk in Uppsala, so I've come out of the session.
Oh wow. Okay, so you're multitasking. So,
I'm multitasking.
Nick, have you had to retract? Well, has a paper been retracted from your journal or falsifying data? Or you don't have to name the paper.
No, but we've had to. In one instance, we had to. It's called a mega correction, which is. It was a paper that needed a lot of work that wasn't really identified as a problem paper in advance. But there was a complex background there, and some of it was. I can send you the link. It was in the end, I put out a whole chronology. It was initially accepted before my time. I have to say, I'm glad to be able to say that. But I was left to sort out the trouble. But it was largely propagated by some protagonists, let's say, from another country who, for reasons best known to themselves, are particularly anti-research in the area on which the paper was based. But that was an interesting learning experience for me, and how to handle that. And I couldn't have managed that on my own. I did that very much in conjunction with the BMJ, with
I was
the
just
editor of the BMJ.
I just recall that the paper linking MMR vaccine to autism, which actually did a lot of damage, but then was retracted. I'm talking about, like, I don't know, about maybe 10 years ago, perhaps.
Yeah.
I don't know what journal it was published in, but
it was
something
in
along those lines.
Yeah, it was in the Lancet. And
it was in the Lancet.
1998, and Richard Horton, who is still the editor, almost resigned over that because he was so. But he, thankfully, he didn't, and carried on. But that caused major damage, and the after effects are still being felt, I think.
Exactly. Yeah. That one paper had to be retracted, but the damage that it did then, and then we're still dealing with that, especially in the US, right? So
exactly. And that's where the author of the paper, despite being struck off, went to next, and he lives there, and he still preaches the same sort of messages, and there are plenty of people who are prepared to believe it, and
yeah, exactly.
So it goes on.
That's true, and Trump probably is housing him.
Yeah, possibly. Probably. Yeah.
Anti-vaxxers living under one roof.
Yeah.
So Hasib has a question for you. Talking about podcasts, was this idea implemented because you knew you had audience to attend it, or you felt the need of it to be discussed on different platforms globally?
Mainly the need to have different platforms, in knowing that people have their own preferences for medium of information delivery, and the podcasts for many people are preferable to print. And they get downloaded a lot. We know a lot of people listen to them. I would like to do more than we already do.
So basically different platforms, right? So just to diversify and get more people to learn from the content. So it's interesting. It's a podcast. Okay. So any other questions or comments? And we've got Fatma and Sidra. We've got Anti as well. Anti, would you like to ask Nick something? You'd like to know more about what we're doing, perhaps?
Anti knows what I do. We work together.
Is he your grad student?
Andy's a PhD student. He's also one of our registrars in Yale.
Oh, okay. What's he working on? What's his project? What's his thesis work?
Oh, he should tell you. He's there now. He's in Nepal at the moment. It's to do with birth asphyxia. It's a brilliant study.
Interesting.
Birth asphyxia and follow up and new ways of following up. You'd be interested. But you and Auntie should have an exchange about this. You'd really like this.
Excellent. Yeah, Auntie, I would love to hear about the work that you're doing. Sidra, Fatma, would you like to ask something? Add to this conversation? We're coming up to the hour. Actually, Nick, this was really interesting. I mean, we've kind of talked about a lot of different things, and not everything was linked back to innovation. Okay, so Sidra is asking, do you think narrative medicine and storytelling can be a creative and alternative method for healing?
Yes, in its broadest sense, I do. It's a separate house conversation on its own. But the straight answer is yes, no doubt about that. Healing both from physical problems and from psychological, functional ones, for sure.
Yep, I agree. Actually, so there's a lot that's been written about how maintaining a personal diary even could be very useful from a healing perspective. So people have maintained their own journals. They've been journaling about their thoughts, chronic pain issues, chronic illnesses such as asthma or diabetes and so on, and psychological issues and depression, trauma, PTSD, right? So a lot of these illnesses, ailments have been people have been physicians and other folks have recommended that people should maintain journals, and could be very helpful. Alrighty, thank you. Anything else, Nick? When are you coming back?
April, I hope.
Oh, okay. All right.
If not before, yeah. Can I get back to some sort of pre-COVID frequency now?
Yeah, that's right.
At last.
Yeah, if anybody wants to reach out to you, is it okay if we kind of, if they can
I'd love it. Of course, anytime, about anything, any query.
Thank you so much, Nick. For people listening, Nick has been really a great friend, colleague, great reviewer of papers, even if he's not primarily involved in the research study, but has given us great feedback, which has helped us refine the papers. So even if it's not original research, obviously, like because of his expertise and experience of academic and non-academic and ways of writing scientific content, if I may, then will give you great ideas as well. So I will encourage folks to reach out to you. Okay, another question from Sidra is, what's the long-term impact of a narrative medicine on reflective capacity and empathy on medical students? Nick, would you be able to address this?
What I'm going to have to go, but if Sidra could email me that,
okay,
we'll have an email conversation about it, because I don't think I can do that justice. I want to answer this now, but I want to do it justice at the same time, and
excellent.
I'm conscious of the time.
No, that's fine. Yeah, that's fine. That's fine. We'll connect Sidra to you for this question. All right, great.
Thank you very much.
Thanks a lot, Nick. Thank you all, and good night, good morning, good afternoon.
My pleasure.
All right,
bye-bye.
Bye.
Have a good evening. Thanks.
Take care. Bye.
Bye.